Gibson approach with a digastric greater trochanteric osteotomy. This is a lateral or posterolateral exposure to the hip. It allows a more direct approach to the superior aspect of the acetabulum. It may be combined with a digastric osteotomy or flip osteotomy of the greater trochanter to improve exposure and allow access to the acetabulum. Access. This approach allows access to the posterior column and wall through the standard posterior hip approach. With the digastric osteotomy of the greater trochanter, the access is expanded to allow access to the superior and anterior aspects of the acetabulum. This approach also allows dislocation in order to repair a femoral head fracture or assess an acetabular fracture reduction from the intra-articular aspect. The indications are femoral head fractures, superior dome fractures of the acetabulum, and certain transverse and T fractures with superior dome extension. Anatomy. This approach differs from the Kocher-Langenbeck approach as the interval to the hip is between the gluteus maximus and medius. In larger patients, release of the femoral insertion of the gluteus maximus will facilitate the exposure. There are two vascular landmarks that help with the approach. There is the trochanteric anastomosis of the medial femoral circumflex artery with an inferior branch of the superior gluteal artery at the cranial border of the quadratus femoris. These vessels identify where the osteotomy needs to be made to ensure that the femoral head remains viable. The posterior dissection is above the superior gluteal muscle and between it and the gluteus medius. The plane of the osteotomy follows the posterior aspect of the trochanter and takes the anastomosis into account. It extends to the origin of the vastus lateralis, which must be elevated from the femur for about 5 centimeters. The greater trochanteric osteotomy is now flipped anteriorly with a sleeve of vastus lateralis attached to it. The piriformis is still attached to the base of the greater trochanter. This allows access to the superior part of the hip and dislocation to see into the acetabulum. If a posterior wall fracture is present, it may be approached by working on both sides of the piriformis, or the piriformis is taken down. The hip can be dislocated in the figure of 4 position of flexion to 90 degrees, adduction, and external rotation. With the head dislocated, a view of the acetabulum can be had, as well as access to fix a femoral head fracture. Patient and C-arm positioning, OR setup. The patient is placed in the lateral decubitus position with the involved hip superior. It is imperative that the hip is able to be flexed 90 degrees, can be fully adducted, and can be externally rotated. The involved side is prepared from the costal margin down both sides to the table and the leg free draped. The landmarks are the femoral shaft, the greater trochanter, the anterior superior iliac spine or ASIS, the iliac crest, and the posterior superior iliac spine or PSIS. The involved leg is free draped. The ability to fully flex, adduct, and externally rotate the hip must be assured. The greater trochanter and femoral shaft are identified. The hip is placed in a neutral rotation position. The ASIS and the iliac crest back to the PSIS are identified. The exposure is between the gluteus maximus and medius. It is helpful to estimate where this might be and place the incision over this interval. It is usually easiest to find this interval slightly posterior to the greater trochanter, so the incision may be curved posteriorly. Sometimes it may be best to have the incision straight in line with the femoral shaft. The incision begins 10 to 15 centimeters proximally to the trochanter and extends 10 to 15 centimeters along the proximal lateral femur. The more obese the patient, the more need to extend the incision cephalad up to the crest. The straight incision is illustrated in this approach. The skin is incised and the incision is deepened through the subcutaneous fat to the gluteal fascia and the iliotibial band. The iliotibial band is opened at the level of the tip of the greater trochanter and extends distally about 8 to 10 centimeters. The incision is extended proximally through the gluteal fascia, keeping as close as possible to the junction between the medius and maximus. Once the fascia is opened, the fibers of the gluteus maximus are shelled out of their fascial attachments to the tensor fasciae lata and the iliotibial band. The distal exposure needs to identify the gluteus maximus insertion onto the femur. This may be incised to allow the gluteus maximus to be retracted more posteriorly. By following the leading edge of the gluteus maximus attachment to the femur proximally, the anterior edge of the maximus is found, which then can be reflected from the medius underneath it. The interval between the gluteus maximus and medius is thus delineated. The gluteus maximus falls posteriorly to reveal the fibers of the gluteus medius. At this point, the leg is internally rotated to better visualize the posterior aspect of the greater trochanter and the quadratus femoris. The trochanteric anastomosis is identified as a guide to the superior edge of the quadratus. Once the quadratus, which is usually out of the zone of injury, is identified, the sciatic nerve is found lying on its posterior surface and then followed proximally through the zone of injury until it dives below the piriformis. An anastomotic branch of the medial femoral circumflex artery and the inferior gluteal system usually identify the location of the piriformis. These vessels are preserved, as they are a redundant blood supply to the hip. The inferior edge of the piriformis is elevated to show the fibers of the gluteus minimus, which are on the retroacetabular surface. The superior border of the piriformis is identified, and the interval between it and the gluteus medius is opened to reveal the minimus below. The piriformis is retracted inferiorly to protect the inferior gluteal anastomosis, and the gluteus minimus is elevated from the ilium. The osteotomy cut is marked on the greater trochanter. It starts superiorly at the tip of the greater trochanter, in line with the insertion of the gluteus medius, and runs inferiorly to the posterior edge of the origin of the vastus lateralis as it attaches to the vastus ridge. The posterior aspect of the vastus lateralis is elevated over a distance of at least 6 centimeters. The more released, the less tension there is on the muscle. The release continues anteriorly so that a Hohmann retractor can be placed over the anterior aspect of the femur. The bone on the posterior aspect of the greater trochanter is exposed to allow for the osteotomy cut. This may be a simple transverse cut or a step cut. Here, a step cut is used. This is the surgeon's preference. The osteotomy is made along the line from the posterior border of the gluteus medius to just below the vastus ridge. The saw blade is oriented upward to avoid cutting into the neck, but still assuring that an ample amount of bone is taken to avoid fracturing the fragment. The trochanter may be pre-drilled for later screw fixation of the fragment. A saw blade is placed in the proximal cut to help guide the orientation of the saw blade for the second cut. Two saw blades are placed in the osteotomy to illustrate the different levels. A small osteotome is used to cut the step. The osteotomy is now complete. This allows for a partial osteotomy and a fracture to occur which enhances the fixation. As the osteotomy is raised, fibers from the gluteus medius will need to be resected, as well as some of the gluteus minimus. When the fragment is freed completely, the hip is flexed to 70 degrees and slightly externally rotated. The anterior hip capsule is now exposed. The hip is progressively flexed and externally rotated more. As the dissection progresses anteriorly, the reflected head of the rectus femoris is exposed. The anterior hip capsule is defined by fatty areolar tissue, which helps identify the correct dissection plane. The minimus may still be limiting the exposure. If so, it will need to be released, usually in the area of the sciatic notch. The best way to do this is to put the hip in extension, return to the notch area, and release the tethered minimus. As the gluteus medius is further elevated, Hormann retractors are placed to visualize the hip capsule. The reflected head is elevated to expose the hip capsule. The longitudinal limb of the capsulotomy is made in the superior aspect of the hip over the bare area of the femoral neck. A vertical incision in the capsule is made near the base of the neck and a tagging suture placed in the corner to facilitate exposure. The remainder of the capsulotomy is made from inside out to avoid damage to the articular cartilage. It is extended proximally to the labrum. At this point, the capsulotomy is extended peripherally around the hip joint, avoiding damage to the labrum. It goes as far as the short external rotators of the hip. With the capsule open and using a sharp bone hook on the inferior neck, the hip is pulled up and out to dislocate the head anteriorly. With the head dislocated, a femoral head fracture can be repaired. A Pipkin type 1 fracture involves the lower portion of the head below the fovea and usually has a retinacular flap. The Pipkin type 2 fracture is more extensive and is above the fovea. By displacing the head laterally and externally rotating the leg, a 360-degree view of the acetabulum is possible. By placing a Hohmann over the inferior aspect of the acetabulum, the head can be further retracted to improve the view of the acetabulum. A fracture reduction of the posterior type injury is possible, but when the joint is visualized by dislocating the head, it will rest on the clamp. Also, there is no control of the ischiopubic segment. When a posterior wall fracture is present, the capsular pedicle to the wall fragments must be preserved. The capsulotomy is modified to incorporate the posterior wall at its margin. The wall fragments are then reflected inferiorly to assist in joint visualization. The labrum is typically intact at the anterior aspect of the wall fragment, but is avulsed at the postero-inferior margin. For many fractures, the surgical exposure is now complete. The capsule is closed. Deep drains are placed as needed. The elevated vastus lateralis will lie in its anatomical position and nothing additional is needed to keep it there. The osteotomy is now reduced and stabilized with 2 or 3 screws, depending on its size. The gluteus maximus tendon is repaired. The iliotibial band and fascia over the gluteus maximus are repaired.